Here at Medical Service Company, we believe in delivering best-in-class service to all of our patients. One of the many ways we care for patients is through offering the necessary equipment to care for the patient through every stage of their COPD diagnosis. We offer home oxygen therapy and use portable oxygen concentrators as our primary mode of portability. This ensures that patients with COPD can remain active and have the best quality of life possible. BiPAPs and non-invasive ventilation are also available, and we have a dedicated team of clinical support specialists that provide patients and their caregivers with the therapy and education needed to support their diagnosis. Our newest addition to our respiratory equipment is a high-frequency chest wall oscillation device, which helps to clear mucus secretions through targeted vibrations. By providing every piece of equipment a patient would need during the continuum of a COPD diagnosis, you can rest assured knowing that MSC will deliver exceptional care to your patient along the way. For more information regarding our COPD services, please reach out to your local MSC territory manager, MSC liaison, or visit our website at www.medicalserviceco.com.
Good afternoon, everyone. We hope you're enjoying a full day of sleep and respiratory education. This afternoon, we will provide respiratory-specific lectures based on your enrollment in the respiratory track. This speaker lineup is designed to further enhance your knowledge in respiratory care. Our first speaker of the afternoon is Dr. Nicholas Prush. Dr. Prush is the founding program director of the University of Michigan's Bachelor of Science in Respiratory Therapy Degree Advancement Program. His expertise in curriculum development, accreditation, and course assessment has been instrumental in shaping the educational landscape for future respiratory therapists. He's been a pioneer in researching ways to reduce 30-day readmission penalties for hospitals, recognizing the immense importance of continuity of care and patient well-being. Additionally, Dr. Prush's focus on chronic pulmonary diseases and pulmonary rehabilitation highlights his dedication to addressing the unique challenges faced by hospitals and individuals with respiratory conditions. Dr. Prush is currently the Respiratory Therapy Program Director and Clinical Assistant Professor at the University of Michigan. Medical Service Company would like to thank Dr. Prush for being a first-time speaker at our JSM Forum. His lecture topic today will be, Does using pulmonary rehab reduce COPD readmissions? During this presentation, please submit any questions you have using the Engage tab, and remember to complete the engagement survey at the end of the lecture.
Hello, my name is Nicholas Prush, and I'm here to talk to you guys about the association between pulmonary rehabilitation and hospital readmissions with patients that have COPD or chronic obstructive pulmonary disease. The objectives today, and what I hope you can take away from this, is to describe the benefits that pulmonary rehabilitation has for COPD patients. I also want you to see and examine whether or not pulmonary rehabilitation would impact COPD readmissions based on this study that we're going to talk about. Also, hope that you can formulate a plan on how to reduce or decrease 30-day readmissions for COPD patients. So let's talk about this. Chronic obstructive pulmonary disease. It impacts many individuals, and in many cases, patients go undiagnosed. They don't even realize they have it. And so this is a problem. It's a problem worldwide. And now the hospital readmission program that we'll talk about has a major impact on how we as healthcare providers can impact COPD patients and the hospitals alike. So pulmonary rehabilitation, is a process in which patients will utilize some form of exercise. And I think from my perspective, it's underutilized across the country. And we'll get into a little bit about that. And then hospital readmissions and the penalties or the fines that are happening due to the Affordable Care Act and how Medicare is impacting reimbursement and penalties. So we'll talk about those. So the gap that we're going to talk about today that is in existence is that we have this issue with there's an abundance of patients out there with COPD. And with this, the hospitals are getting penalized if they're getting readmitted within 30 days. So the gap exists in trying to figure out a way that we can help hospitals reduce 30-day readmissions for the COPD patients. So a little bit further on the background and why this study came about. A hospital in McLaren-Lapeer Regional Hospital, it's in Michigan. What they did here is they got a grant, and the grant was given to us, or given to them, I should say, to help look at COPD readmissions. And with the COPD readmission rate, their current in 2017, when they attained this grant, they had a 27% readmission rate within 30 days for their COPD patients. And they looked at this data that we're going to talk about. And what this data has helped them do is to start a navigator program, so a COPD navigator program. And with the COPD navigator program, it allows them to get a respiratory therapist in the home with help reduce COPD readmission rates. So we'll talk a little bit more about that as we go along. So what is COPD? See, CDC says that there's about 16 million individuals diagnosed with COPD nationwide. And there's probably more than that undiagnosed that have it. They either haven't been able to see a physician, they haven't been able to see their primary care individual, and they go undiagnosed, but they still have symptoms. And these symptoms that go along with this is the biggest one is shortness of breath. And people that have shortness of breath, they kind of just blow it off. They're like, oh, I can make do. They have trouble going up the steps. They no longer go to the shopping market to go get groceries. They might start to order in and pay those extra fees to have groceries brought to their home because they can't walk those types of distances. And they don't realize they might have COPD because of the inability to get the care that they need. On top of that is the cost associated with COPD. People are unable to get Medicare or Medicaid don't necessarily cover the cost for the medications they need to get on a month-to-month basis. I have loved ones that was just presented to me just recently. The cost of one of their inhalers was about $250 a month to get this inhaler that they need. And they're on Medicare, Medicaid, and $250 a month. I mean, for some people, that's a lot of money when you're a retiree. So that cost, just being able to get those medications, can impact your quality of life that we'll focus on here in a second. And then the risk factors. The primary one for COPD is smoking. And it continues to be a predominant impact. And that's the predominant kind of cause for COPD is smoking. And you're starting to see the baby boomer population retiring, and they're becoming less active. And so now they're getting these more and more symptoms because they're becoming less active. And so they're starting to see these symptoms flare up more and more. They're still smoking, essentially. And so they kind of need this push to try to quit and or see how some of the things that they're doing on a day-to-day basis can impact their quality of life. And that's the primary focus, really, when we're looking at this type of, study and the things that we're going to talk about today. The focus of COPD patients is their quality of life. We want to have a primary focus on their day-to-day activities, allow them to go see their grandchildren. And I say grandchildren because predominantly the age group, let them go see their grandchildren play sports. Let them go shopping and get out of the house. Let them drive to places, go get coffee with friends now that they're retired. Try to be able to live their life as normal as possible. So what is pulmonary rehabilitation, or pulmonary rehab for short? As you see in this picture, it's really, it's a tailored program that can be individualized for each person. And it doesn't necessarily have to be the same for each one. But in this case, these individuals you see on the screen, they're doing exercise training. And the exercise training just allows them to help impact their quality of life. Maybe they get short of breath going up the steps. Maybe they have 1 or 2 steps at home, 3 or 4 steps at home, and they get crazy short of breath. This exercise training is to help build up that reserve that they have and give them some type of training so that they don't get short of breath when they're walking around or going up steps. You'll see most of them have ankle weights. Okay. They're probably doing knee ups. So it's helping them build up some muscle, build up that ability to take deep breaths, build the muscles up so that when they're walking, that they're using less energy to do all of the things they're going to need to do in their day-to-day living. Symptom management. For me, this is understanding the symptoms. So in pulmonary rehab program, it's a very patient-centric model where they might not know what their symptoms are, right? They don't know if they're short of breath. They don't know what it means to get an allergic reaction or to have a response, like what's an exacerbation, so to speak. So allowing them to know what their symptoms are and then how they can manage them, right? If they have oxygen therapy at home, you see this individual wearing a nasal cannula while he's doing his training, and a patient's getting really short of breath. We don't want them to go quickly, automatically to go do their inhaler, where if they have oxygen therapy at home. So to reduce the shortness of breath and the work of breathing, and they have oxygen therapy, that's probably what we want them to do. So we model that treatment plan and allow them to understand what the symptoms are and how they can best maintain them at home, excuse me, with the hope of reducing 30-day readmissions, right? So these individuals might have just got out of the hospital. They're attending this pulmonary rehabilitation program. If they can now have a better understanding of how they can manage their symptoms at home and not automatically take a car or have a loved one drive them to the emergency room, it can impact the 30-day readmissions. Another large piece to pulmonary rehabilitation is smoking cessation. So during the discharge planning process, there's packets of paper, like papers given. It could tell the patient, why they were there, tells them the meds that they're on, talks to them about their disease. But how many times have everyone in the audience, how many times have you been in the hospital or went to the urgent care or the emergency room and you get that packet of paper and you just throw it up in the visor of your car on the way home and never look at it, right? It happens a lot. In fact, I think mine is still there from the last time I went and saw somebody in the ER. I still have my care plan sitting on top of my visor, and I've yet to pull it down. It's probably been in there for a good 6 months now. And I'm a healthcare provider, and that's not just the standard average person that has no idea what's going on. The realization is they're not reading that information. And if you're going to talk to them in the 20 or 30 minutes that you have, as they're just worried about getting out of the hospital, they're not going to listen to you really with that content to say, yes, I want to quit smoking in that 20 or 30-minute time frame. So getting into this pulmonary rehab program, it gives the healthcare provider, most of the time it's a respiratory therapist, the ability to sit down with them and really counsel them on, here's some ways and mechanisms that we can help you stop smoking. Have you thought about stop smoking? Take some ownership, right? They're not going to try to stop if they don't want to stop. So you got to just get that in their head to say, what is it about, your COPD symptoms that you want to get rid of? Do you want to minimize your exacerbations and flare-ups? Okay, well, the first way to do that is to stop smoking. And here's some pathways and avenues to start doing that. Mental health, this is huge. Mental health is an issue. And what this does with pulmonary rehabilitation programs, it gets patients that have similar comorbidities, similar concerns. Not everybody has COPD in a pulmonary rehabilitation program, but they have similar comorbidities, and they can sit around and understand that they're not alone. They now have a creation of a social network. It's fun for them to come to pulmonary rehab because they get to see some friends that they're making, and they can go have coffee with their friends after their pulmonary rehab is over, have breakfast, and create this network of like individuals. So now they can start talking about it. And you have one person in the group that might have stopped smoking, and they can start giving them tips and pointers and saying, hey, if I did it, you can do it. And now creation of this mental health picture to say they have a support system. Everybody needs a support system, especially when they're dealing with symptom management, dealing with things that they may never heard of before. Now they might be newly diagnosed. What do I do? And now they get in this room and they're doing these exercises with individuals with similar disease processes who have been through it and gone through it. They can now have that discussion and help with their mental stability. Now, hospital readmissions, and trust me, I use the picture like, stop, don't come back. We don't want patients to come back. And guess what? The patients don't want to come back either. But if we don't do our due diligence, if we don't do the job that we're supposed to do within that window of them being in the hospital, then we should be penalized. And we need to make sure we're doing a better job. And that's where this hospital readmission reduction program kind of comes in. So this was created as part of the Affordable Care Act. And it holds acute care hospitals, it holds them accountable for patients that have Medicare, Medicaid benefits. And what happened it didn't initially include COPD, but it broadened its kind of scope and added COPD for this 30-day readmission penalty. And an interesting stat, if you were to do this and look this up, but I did it for you, out of about 3,200 hospitals, acute care hospitals that actually report this information, out of about 3,200, 93% of those acute care hospitals have been penalized with this hospital readmission program. And that's just focused on COPD, not looking at the other ones that are involved. And so if you look at that in a percentage, about 93% of all of the hospitals that are using this and reporting this data, and that's over the course of a 10-year cycle. So when Affordable Care Act came out, looking at it through that 10-year cycle, 93% of the hospitals are getting penalized. And that's important to know as we move forward, because I'm going to, hopefully, by the time this is all said and done, that you can have an understanding of how we can help improve these 30-day readmissions and in hopes that we eliminate them altogether. We don't want hospitals to be penalized. And what I mean by penalized is they have to pay a fee, right? They're getting up to a 3% penalty that Medicare is forcing the hospitals to pay based on the number of readmissions that they have over the course of their annual cycle. On top of that, a patient that is brought back into the emergency room within that 30-day window, regardless of why they were brought there in the first place, right? A readmission, it doesn't necessarily have to be if they came in with a COPD exacerbation. It doesn't mean they come back with another COPD exacerbation. So it says the HRRP doesn't matter what the principal diagnosis is. And it doesn't matter if you go to a different hospital, they find you, right? So you could go from one hospital to the next and be like, oh, well, you're not going to get penalized. Yeah, you're still going to get that penalty because the patients come back within that 30-day window. In the hope of this, the idea behind this, Medicare uses this value-based program that really wants hospitals to encourage a better care coordination and engage the patients. And that's very important as I move forward in this talk today, is understanding that this program was built in terms of creating a better care coordination plan of this patient to engage patients and the caregivers in the discharge planning process. And the point of this was to avoid hospital readmissions. So let me say that again. We want to better engage patients. Okay, that was the goal of the HRRP, is to better engage the patients and hold them and the caregivers more accountable in the care to help reduce 30-day readmissions. So why does all that matter in the grand scheme of this? I'm going to talk about that when I start speaking to the study. So the problem statement is, if you haven't gathered this yet, the COPD patient is very complex. There's a multitude of symptoms. They don't necessarily know that they have it all of the time, and they don't know what their symptoms are unless we're doing a really good job educating them. And the issue is there's a lot of them out there. And the COPD patient, because it's so complex, that we have to find a way that we can control their symptom management, but also allow them to take ownership to control their symptom management at home to avoid just coming to the ER to feel safe all of the time. So how do we as caregivers make them feel more comfortable on their own and hold them a little bit more accountable? So I talked a lot about the CMS, so the Center for Medicare and Medicaid Services, the hospital readmission program or reduction program with 30-day hospital readmissions. Okay, the idea behind all of this is to reduce that 30-day window for COPD patients. There's other disease states that are in that window, but I'm not going to talk about them today. But the idea that they want what Medicare wants to do is they want to capture all unplanned readmissions that happen within 30 days of discharge from that primary admission. So if you come into the hospital with a COPD exacerbation and we discharge you after, say, 8 days in the hospital, and then that, as soon as you are discharged after that 8th day, so if we use like the 10th to the 18th, when you're discharged on the 18th, you have 30 days from the 18th that you have to stay out of a hospital. Otherwise, you get counted in that penalty fee, or you get counted as that 30-day readmit. To date, I believe this number is a little bit higher. If we look at this study was done in 2021. So we have a couple extra years, but there's been over $500 million in fees that have been paid. And if you look at it from the flip side, Medicare, Medicaid services, so Medicare has actually saved themselves roughly $520 million in having to pay out for these readmissions. So you look at it from both sides, right? So Medicare has designed this to help hospitals kind of fix the problem of we're getting a lot of readmissions, right? So we need to figure out how we can, as a hospital, determine the best way to keep patients out. And they've said you have a better care coordination plan, and you better include patients and caregivers in that plan. And then Medicare and Medicaid say, well, if we do this, how much can we save? Well, they've saved themselves about $520 million over the course of this. So why the study? Like, why are we here? Why have we done this? And what's the point? Well, number one, I don't think many individuals outside of a respiratory therapist, a pulmonologist, we don't understand necessarily the benefits to pulmonary rehab. We don't really understand what we can do and help patients nationwide. On top of that is the hospital readmissions for COPD patients. It's clearly an issue. And because it's an issue, there has not been a formalized plan that says, well, if we do this, we can have a major impact on the readmission of a COPD patient. And so that was the purpose of why we did this study. And the study really is to look at how can we impact 30-day readmissions? Is it if we use pulmonary rehab, if we have a patient that's discharged, participate in a pulmonary rehab program, and specifically for this study, it was a 6-week pulmonary rehabilitation program. Did it impact hospital readmissions? And then as I was putting apart all this data, it was, okay, well, maybe age plays a factor, or maybe BMI plays a factor in whether or not a patient comes back within 30-day readmissions. And so we looked at all of this and the impact that it had on the 30-day hospital readmission. And then I just kind of clumped all the other medical conditions. So these were, for me, it was all the comorbidities. So if you had a COPD patient that also had congestive heart failure, or maybe diabetes plays a role. So those all fall in that other medical conditions because remember, the HRRP program, that readmission reduction program, it says no matter what that principal diagnosis is, you're still coming back to the hospital within 30 days. So if a patient has comorbidities, we have to educate them on those symptom management, right, of all those comorbidities that they have, and not just that primary diagnosis that they're being discharged for. And I think that's important as we move forward. So the research questions that I looked at was I went into this in saying that, is there a difference between readmission rates of patients that have COPD who participate in pulmonary rehab compared to those that don't, right? And we say, if you go to pulmonary rehab post-discharge, you're most likely not going to come back to the hospital within 30 days. That's kind of the research that we're going into this. And then on top of that, I wanted to look at the relationship with age, because ideally, like, again, as I think about my hypothesis, right? So I hypothesize that if we can get every patient that's discharged from the hospital to participate in a pulmonary rehabilitation program post-discharge, we can impact 30-day readmissions. And I feel strong about that as I move into this study. And then I started to debate to myself, and I said, well, I have the data, let's look at this, that I think there's a distinct correlation between the older that an individual gets, the more likely that it would impact their 30-day readmission. I just think with the way age impacts us, it impacts us all a little bit differently. But the kind of thinking about that mental health model, whether or not age impacted it. So again, I thought, or as I hypothesized this, I feel strong that you would see a distinct correlation. The older somebody is, the more likely they're going to be readmitted within 30 days. So the design of this was a quantitative study, cross-sectional design, and I used simple linear regression for the dependent variable, and looking at all the ones that if I go back a few slides with age, BMI, pulmonary rehab, and then I also did a multiple linear regression to look at how multiple independent variables impacted. So I kind of clumped them all together. But I want to focus more on that simple linear regression model when we start talking about it. The conceptual framework, and this is a big piece to this study, right? So if I go back to the HRRP program, where the goal for Medicare was to encourage hospitals to improve communication and care coordination to better engage patients and their caregivers. I said that. This is probably the third time I've said that. And so the framework around this is this health empowerment theory. And what the health empowerment theory does is that we can transform, it basically gives the patient the tools to basically hold their own, the way that they're being cared for in their own hands, right? So give them and empower the patient to have some type of recognition type purpose. Like, give them some recognition, give them context to hold their selves accountable for the care that they're getting, the care that's being provided, the medications that they need to take. The health empowerment theory focuses on that. And when I looked at this study, it was a big thing to really use this kind of framework, because the goal of the HRRP is to make the patients a little bit more accountable. So here, looking at this, was find out what the goal was from the patient, right? What is the goal of the patient? Do they want to be able to go up the flight of steps? Do they want to be able to go see their grandchildren play soccer or basketball or whatever it might be? On top of those things, really have the outcome of what it is that they're trying to perceive, and understand that what COPD is going to cause for them. Like, what is the outcome of now you're newly diagnosed, or now you've had COPD now for 5 years. Here's what the expectation is and where this health outcome is going to come from. So that's kind of the idea about why the health empowerment theory was utilized in this study. So diving a little bit deeper and really why health empowerment, like why the intervention of using health empowerment. It was to really get the patients to purposefully participate in that goal attainment, right? Give them empower them to come up with a goal. Many people don't have a goal. I tell students all the time, you should have a 3-year goal and a 5-year goal. Because if you don't have a goal, what is it that you're chasing? You always want to be chasing something. And so in this context, giving the health empowerment theory to the patients, you create a goal for them. And now during this pulmonary rehab program, sitting down with them and saying, I have a 3-year goal to stop smoking. Now they have a time frame. They now have a goal for them to kind of push and a purpose, right? So everybody, if you don't necessarily have a goal and you see these patients diagnosed with COPD and that mental health, they might lose focus on what their purpose in life is. And it's a sad thing when we start talking about it, because they're retired, they're at the kind of that end, they see themselves at the end of their life. And they're like, oh, well, now I have COPD. I have nothing to kind of push for. So our job as healthcare providers is to give them that purpose again, but also make them own it. Make them be self-acceptance to this. And then our job in this goal attainment is to say, okay, you've made this goal. Here's how we're going to get there. Our job as healthcare providers during this pulmonary rehab program is to give them those options to get there. Right? And say, you want to quit smoking in 3 years, here's how you're going to do it. We're going to give you an idea. You're going to put money at all your ashtrays. So every time you go to sit down and you're at an ashtray, you're going to have a $5 bill you're going to take, and you're going to save all this money. At the end of the year, instead of smoking for that year, you're going to have $3,000 to go on a vacation because you saved up. Instead of spending that money on a pack of cigarettes, you put it at your ashtray each and every time you were doing that. So you give them these options. You create the awareness around their goals and say, you can do this. You give them that purpose back to their life. And then the health outcome is to let them know that if they do these things and they follow through with all of these things, here's what your quality of life can be and will be when you do these things. So at the end of all of this, here's where you can be. You can go to these soccer games. You can go shopping and get your groceries on your own without having to wear an oxygen tank and carry it around with you. You don't need any of those things. And so that's really what this theory did around the patients. So the participants in the sample size. So in the sample size, this was from COPD patients who had Medicare, Medicaid services. I say a hospital in Michigan, that's McLaren-Lapeer Hospital in Michigan. The data, the sample came from, it had both male and female patients aged 48 to 90. And when I did the power analysis, this G-power analysis, it wanted to determine the power. So at an 80% power, it requested me to have a sample size of 128 patients. And as you'll see, we superseded that by more than double in the actual sample. So how did I collect the data? The data was collected by de-identified sources. So the hospital supplied me with the data through a password protected Excel file. I did not have to recruit any patients. This was retrospective data that came to me from patient charts through the course of 2017 through 2021. So a 4-year window of data from all the patients that were seen at McLaren-Lapeer who had COPD and Medicare, Medicaid services. I did not need any instruments or any recruitment necessary. So that's how I was able to obtain this data. And so I looked at this simple linear regression between, is there a difference of utilizing pulmonary rehab with patients that have COPD in 6 weeks of pulmonary rehab versus those who don't? And then is there a relationship between age and 30 days? So just kind of a recap. of what those research questions were and understand how the data analysis plan came about. So this was the total data set. It actually had over 250 some patients, but there were some that were taken out because they didn't meet the kind of the window or the threshold that I had set forth with the age. So overall, we had 209 patients overall, and of those 209, 25 patients that were readmitted. That was the only readmit number there for the results. So I looked at simple linear regression based on this, and we looked at age, BMI. I kind of clumped those in there. You'll notice that age, the minimum age was 47, the maximum age was 96, with a mean average of right around 70. So again, looking at this from a COPD perspective, here's your 209 patients. That average age of those patients are 70 years of age. And so going back to trying to think about how we can have an impact on their quality of life is really important. They're most likely retired, and they're trying to enjoy these years of their life. So how can we impact them in a way that gives them a meaningful quality of life? So looking at that data, breaking it up into the variable results. So it was pretty close, female and male. So 47% between female and male. The BMI breakdown is listed there. And the reason once that data came about is why I focused a little bit on BMI to see if BMI did impact. Although that was not a primary research question, it was something that I looked at, just knowing that BMI was kind of elevated in many of these patients, over 25 for over 60% of the patients. So I did end up looking at that here at the end, and I'll kind of talk about that. Now, pulmonary rehab, only 21.5% of all these patients actually saw pulmonary rehab. So out of the 209, only 45 actually saw and went to pulmonary rehab. And of those 209, we did have a 12% readmission rate. So 25% of them were readmitted within that 30-day window for this course of action. Looking at this in context using that simple linear regression, what happened was there was no statistical significance in any of these. So sex did not have an impact. Age did not have an impact. So then I told you I looked at BMI. BMI did not have an impact. Pulmonary rehab did not have an impact. So I'm going, okay, so I went into this with an understanding of, yes, this is all going to be great. It's going to be, if we get them to pulmonary rehab, it's going to impact readmissions. Well, in fact, it did not. It didn't have any impact on, or I should say, I can't say it didn't have any impact. I can say based on the statistics, it did not have a statistical significant impact based on the data set that we had. It did impact COPD patients overall. Pulmonary rehab can do that. But it did lead to more questions. And I go back to this data because it did lead me to more questions, right? So why did pulmonary rehab not impact? What was the issue with pulmonary rehab, or why did we not have an impact? Or why, if we go back to here, why did not more people get to pulmonary rehab? And it comes to find out as you dive into this, and when your data set didn't really match what your hypothesis, it created more questions. But I dove in and tried to figure this out. So we send patients home, we give them all this education, and we just expect them to go find their way to pulmonary rehab. Well, guess what? They don't. And a lot of times they don't get to pulmonary rehab until probably on average, it's about 18 to 21 days is when they're getting to pulmonary rehab. So if they have an exacerbation post-discharge within that 2 to 3 week time frame, where are they going? They're coming back to the emergency room. There might be a phone call. There probably isn't, but it might be a phone call just to see how things are going. But nobody visits the home. Nobody goes and sees them to check on them. Nobody goes and makes sure they filled their prescriptions. So all of that played a factor in how all of this data, so we talk about, well, it didn't answer my question, it didn't come to about, but what are the implications and how can we actually take this data and take this study and what's happening and have a really big impact? And that's where this social change impact or implications can be. COPD patients, we need to educate them. So the social impact is that we allow them now to have ownership that they do have COPD, but we want them to educate themselves and understand what are the symptoms or what are our kind of risk factors for exacerbations. So if you're a smoker, you need to stop smoking, otherwise you're going to have exacerbations. Understanding the seasonal changes and the impacts that the seasons can have. Understanding what their quality of life will look like now that they've been diagnosed. What can we do or what can they do to understand quality of life? Get to pulmonary rehab. All of these things are going to be improving, or the goal is to improve their quality of life for that day-to-day activity. Hold hospitals accountable. So hospitals are already making this change. The Affordable Care Act has kind of pushed that. Now, COVID has impacted a lot of things, so you're going to see a kind of a relight or a refocus or recentered focus on this type of thing, these readmission rates. Now that COVID is somewhat past us, I think, or at least we're out of the public health emergency. But the hospitals really have this primary focus because of this value-based purchasing program that Medicare holds them accountable to. And you're going to start to see a focus on reducing that penalty that they have to pay. Again, I think the national average is around only about 0.6 or 0.7% is the penalty cost of that total penalty. But the highest is 3%. So you think that's a lot of money that a hospital might have to pay in penalty costs if they're paying that 3% number. You're starting to see, if you're not familiar, but there's a reduction of readmissions. So this program, this study essentially opened the eyes of this program here at McLaren-Lapeer to reduce readmissions, right, and have a focus. And I'm going to talk about how they did it in a second, but they reduced readmissions, and they reduced it down to about 7% total 30-day readmissions. And I'll explain how they did that, because I think that's where we need to go. That's what hospitals, if they haven't done this, you're going to start to see a larger focus on it. Also, the ability to identify patients at risk, understanding those early on. And I think, again, that is part of that holding hospitals accountable, holding healthcare providers accountable, whether it be the respiratory therapists, the nurses, the physicians, the social workers, right? To identify patients who are more at risk to be readmitted within 30 days. It can be just something as simple as that, to have that risk factor sheet to say, are you still smoking? And it could be questions you're asking upon discharge, and having those things help identifying them so that you can be able to follow up a lot faster, whether it's in 3 days, 7 days, 10 days, however you need to follow up to impact that 30-day readmission. So why does all this matter? Like, all this is great. All this is talked about. You're talking about COPD, pulmonary rehab. Like, I knew all about those things. But see, there's a study about Kreiner and Hahn in 2018 that says, we know this is happening, but there's still no plan. Nobody's created this formal plan. So what are we going to do about it? We have all these penalties. Hospitals know it, but they're not doing anything about it. Well, on top of all of that, of all admission reasons, COPD exacerbation equate to over 60% of those. That's a lot. So COPD is an issue. The highest related cost of an emergency readmission that's accounted for is COPD. And across the United States, of all readmissions within 30 days, that number is still over 20% across the United States. With all this information that's out there, these hospitals know they're getting penalized. There's not a model that you can use to date that can reduce 30-day readmissions, or is there? So, benefits to patients with COPD. I talked about this. I don't want to beat this home, but our goal is that we improve their quality of life. On top of that, I think it's to increase access to care. And I'll talk about how this new model that came about will increase their access to care. I think from a hospital perspective, they know they're getting penalized. They know they have to reduce readmissions. So they've changed models, right? The model has to change how they go about it. Everybody's doing things just a little bit differently, but I want to create and talk about this model that I think can impact this 30-day readmission. So this is the plan moving forward that I hope many hospitals nationwide or worldwide can do this. And that is create a COPD navigator program. McLaren-Lapierre model has it. They're saving their hospital money. They've reduced readmissions. They were over 20%. I believe it was 24%. They're down to around 7% with 30-day readmissions. And so you say, well, what did they do? What's the biggest primary thing? Well, they're doing in-home visits. That grant that they got funded allowed them to fund a respiratory therapist full-time for this program. And the main or primary goal of this respiratory therapist was every Medicare patient that was discharged from their hospital saw a respiratory therapist in their home 3 days post-discharge. And that respiratory therapist has a plan. They go in, make sure they have their meds, make sure they have long enough oxygen tubing to get around the house. They make sure they understand what COPD is, what their symptoms are, symptom management. And it holds and find out the goals. Like, what is the goal of the patient? And you set up and create this plan and say, oh, by the way, you're going to pulmonary rehab tomorrow or on day 5 post-discharge. And so now, and they're like, well, I don't have a ride to pulmonary rehab. The respiratory therapist goes and gets the patients and takes them to pulmonary rehab. So I think what you're seeing, and that's somewhat that I didn't speak to, I think the accessibility to pulmonary rehab is a concern. And the ability to get appointments and get scheduled and get to them. And this program that McLaren-Lapierre has modeled allows that RT or the caregiver to get these patients where they need to go, get them their meds on time, and all of those great things. Now, from an advocacy perspective, what's happening in Washington, D.C., the public health emergency afforded or allowed Medicare to bill, or I guess reimburse, the billable of telehealth pulmonary rehabilitation during the public health emergency. So COVID found that it was a great thing, right? Well, when the public health emergency, when it went away in May, something slipped through the cracks, and that was the reimbursement for telehealth pulmonary rehabilitation. It's no longer available. So those services are going away. And that's a problem because we need to have pulmonary rehabilitation, right? So there's a bill that's being introduced. So I ask all of you to pay attention. If there's anything that you can do on your behalf to support this, advocate for this, it's HR 1406. And basically what that will allow is it would allow telehealth pulmonary rehabilitation to have reimbursement along the services of patients and being able to get access. We talk about access a lot, so it gives more access for these COPD patients to get these services. And then lastly, oxygen reform. So CMS says that if you need oxygen, you're going to get the bare minimum, right? Regardless of how much oxygen you're on, CMS says you're going to get this. You need 6 liters, you're going to get 8 tanks. If you need to go somewhere, we don't care. You got to carry these tanks in your car, all of those great things. It doesn't allow the caregivers or the healthcare providers to pick which type of oxygen is best for the patient. This oxygen reform is around 4 pillars, and basically the largest one is going to allow the healthcare provider to determine which form of oxygen therapy suits the patient best. And then it would be reimbursed by Medicare, Medicaid services. So that's coming too. That bill's in draft form. Hopefully we get more information on that. So again, pay attention to that. We would love support on that. So with that, I thank you all for your time, and I would love to field any questions that you have. And references should you feel suited to check on them. Thank you.
Hi, I'm Keith Heck, Regional Sales Manager with Medical Service Company. Thank you, Dr. Prush, for the very insightful presentation regarding COPD readmissions. So thank you for your time today. Really do appreciate it. So looks like we got some questions rolling in. The first one that came up is, what did you find was the cause of the delay in pulmonary rehab onset? And what can be done to improve that? I know you said in your presentation roughly 18 to 21 days. Why is that delay? What do you
Yeah,
think?
I think this is one of the questions I think in the chat as well. I believe it's access, patient access. So insurance is number one, right? So the insurance has to, that pulmonary rehab facilities will not allow patients to get in there without getting that insurance authorization, and that could take a long time. So insurance authorization, and then once they get this insurance authorization, they have to schedule it. And because there's a lack of pulmonary rehab programs available, it's really, really difficult to get scheduled. It's a 2 to 3 week window just to get scheduled. So, as someone typed in the chat here, I see Andrea wrote that she doesn't see a lot of programs around, and I agree. There should be more programs around. Why isn't there programs? I think it's the inability to get reimbursement. So a lot of these healthcare facilities, unfortunately, don't see a benefit because they're going to be paying out for the expense of having the machinery, having the facility, having the workers staff it, and they don't get reimbursed for the services. And that's it's really, really sad to say, but I think that is really what is causing the lack of pulmonary rehab programs right now.
Gotcha. All right. Moving on to the next question. I know with the COPD Navigator implementation, and it has been successful in many areas, why do you think more hospital systems don't incorporate that strategy?
I think it's starting to become more of a popularity. It's gaining traction. Initially, I think what the issue was again was cost. So having to get a full FTE to house whether it be a respiratory therapist, a nurse, physical therapist, whomever, PA, to get with every COPD patient. So you think about a full FTE and the cost that it's going to manage on somebody's budget line item, and then to facilitate all of this to go into their homes. So you're talking about mileage. You're thinking about safety, the safety of your employee, the employee that has to go inside these homes. All of those things kind of played a role, but then you start to see these places like McLaren, Lapeer, where they're starting to see a benefit to this, right? So it is impacting the bottom line. So they're saving money, reducing their penalties, having a readmission rate around 24%, and then decreasing it to right around, they're around 7.5, maybe 8% with their 30-day readmissions now by implementing a COPD navigator. So you take that offset of 16% and find the penalty cost. I think over the course of this 4 to 5 year window, it's saving the hospital millions of dollars in penalties. So it's pretty impressive to see. But again, it all does boil down to the patient and whether or not the patient wants to do these things, right? So we can give them everything, we can get them access, we can go to their homes, but does the patient want to quit smoking? Does the patient want to go to pulmonary rehab? We can go pick them up and bring them, but are they willing to do all of these things? And in some cases, these patients just don't want to do it.
Right. Yeah, that commitment definitely needs to be on their end as well. All right. On the next question that we have that came in, so in addition to that COPD Care Navigator, are there any other strategies that you can think that could be implemented to really kind of further decrease those readmission rates?
Yeah, I personally feel like we need to do a better job educating our patients and families while they're in the hospital. So this discharge planning process within our healthcare systems, giving people a packet of papers to say, you've been diagnosed with COPD. Here's what it is. Here's the medications you're getting. I just don't feel like we're doing a very good job in our health. And it's not all the way across the board. I don't want to put everybody under that umbrella, but ultimately we as a group, as healthcare providers, we need to do a better job educating our patients, educating our family members on what meds they're doing, what things they can do at home, what it looks like or what it feels like to be in an exacerbative state, or something. What are the triggers, what are all these variables, and instead of just letting them read about it or telling them to Google it. I think making sure, going through, getting I think in terms of discharge planning, getting a care team together, making it multidisciplinary, and having a multidisciplinary care team doing the discharge planning, so that all bases are covered and not just to the patient. And it should be like, I don't think it should happen 20 minutes or 30 minutes before someone's being discharged, right? It should be, okay, we know Mrs. Smith is getting discharged tomorrow and it's 2:30 in the afternoon. Let's go talk to them now, and then follow up again the next day before they're going home to see if they have any questions about the stuff that we talked about. And maybe in some cases this is being done, but I still feel strong that we can do a better job with discharge planning.
Right, right. Okay, good. Now, the next question that came in is, do you see any disparity of wages for an RT working, in pulmonary rehab versus an inpatient RT?
No, I actually think that I think I think the wages are a little bit better. I know the hours are a little bit better for outpatient clinics, so they don't work weekends. That's another thing, right? So we talk about access.
Hmm.
These outpatient clinics aren't, they're not housed, or they're not running on Saturdays and Sundays. Maybe Saturdays and Sundays would increase the access for individuals, and because they might be working during the week, so they can't get there. So the wage piece is not an issue, but scheduling, I think the pulmonary rehab folks work a Monday through Friday, maybe 9 to 5 type piece, whereas an inpatient only works 3/12s. So scheduling's a little bit different. Wages probably relatively the same.
Sure, sure. Yep, no, good there. So next question, so motivational interviewing certification, is it worth an RT obtaining, in your
I
opinion?
wouldn't discredit it, right? I think every person, like every healthcare, not just RTs, interviewing, getting a certification that can help better yourself, I don't see why that would be an issue or a concern. It would only make things better. But I think from a healthcare perspective, we think of, what might benefit the patient the best is looking at that multidisciplinary approach. So maybe the RT is really good at speaking to the patient or whatever, but they might not be involved in that discharge planning piece. It might only be a social worker, maybe PT, OT, and the nurse. And the RT is not, doesn't know that they might know that the patient's being discharged, but they didn't get involved in that discharge planning and explaining, okay, you now have been diagnosed, or you have COPD. Here's the meds you need to get. Um, just from experience, both being, from seeing family members and then knowing and working inside the hospital, you get a pharmacist comes up and fills those scripts and hands you a bag and says, "Here's your meds," and
Right,
then walks out of the room. They'll
right.
say, "Hey, do you have any questions about these medications?" "No, we're good." And then they leave the room. It would be nice for, again, that multidisciplinary approach where maybe an RT comes in there if they're getting inhalers filled, to then show them how to use it, use the spacer. All of those things I think will impact readmission rates.
Gotcha. Well, that's great insight, Dr. Prush. Really appreciate you participating in the JSM this year, and look forward to talking with you soon. I think we're out of time, so thank you again.
Thank you very much.
All right, take care.
Bye-bye.